Okay, so where were I? So we finished aphthous ulcer, and now we are going toward the second part of the aphthous ulcer, that is Behçet's disease. Okay, this is the occurrence is between the age of 20 to 40. Yeah, so we have 20 to 40 incidents, the case, age for the Behçet's disease, and then this is one of the recurrent oral ulcers. Diagnosis is that oral recurrent ulcers with two of the following. So how to make a diagnosis with Behçet's disease? A very important question. How to make a diagnosis? There will be recurrence of oral ulcers. Recurrent oral ulcers like minor aphthous ulcer. So there will be recurrent minor aphthous ulcer, but this one looks like major. At least 3 times within 12 months. So in a time period of 1 year, there are 3 times, at least 3 times of reoccurrence of oral ulcers, which are like minor aphthous or major aphthous ulcers. Okay. And then other than this, we have 2 of the following 4. 2 of the following 4. What are these 4? Along with the oral ulcer, there can be recurrent genital ulcers, as you can see here on testes. There can be recurrent genital ulcers. There can be eye lesions, including uveitis, retinal vasculitis, or corneal inflammation. Then one is genital, one is eye, then there is skin. What about skin? There can be maculopapular lesions, erythema nodosum, which is reddish, painful, tender lump, right? Excuse me. So what we have, let's just mark with this and this. We have genital, we have eye, we have skin, and then we have positive pathology test. Among these 4, if 2 are there, then we'll say, okay, these are the condition known as Behçet syndrome or Behçet disease. So genital, here you can see genital. And then we have eye lesions, here you can see. What do you mean by relapsing, reoccurring? And then we have skin lesions, which are maculopapular lesions or erythema nodosum. Okay, perfect. And then finally, we will have positive pathology test. Okay. So if a person has recurrent oral ulcers like minor aphthous ulcer at least 3 times in 12 months or 3 times in 1 year, plus 2 of these 4, either genital ulcers and eye lesions, or genital ulcer or skin lesion, or positive pathology test, this disease or syndrome will be named as Behçet syndrome. Behçet syndrome. Okay. Among these, you already know the oral recurrent ulcers, minor aphthous ulcer, you already know. Recurrent genital ulcers, you can see. Eye lesions, you can see uveitis, retinal vasculitis, corneal inflammation, reddish eye. And then you can see the skin lesions, which includes erythema nodosum, maculopapular lesions. And the remaining is positive pathology test. What is positive pathology test? This is a cutaneous skin involved hyperactivity to intracutaneous injection. So you inject something under the skin with the pathogen. Within 24 hours, there will be appearance of small red bumps or pustule. So here I included a picture for mucocutaneous pathology test. Very important. The pathology test is helpful in diagnosing Behçet's disease. It is a simple test in which the forearm is pricked with small sterile needle. Okay, it's a sterile needle, excuse me. Occurrence of small red bumps or pustule at the site of needle insertion 1 to 2 days after the test constitutes a positive test. So what they do is at the forearm, they will use a small or sterile needle, they puncture it, and after 1 or 2 days after the test, after the puncture, there will be occurrence of small red bumps or pustules at the site of needle insertion. This will show a positive test. This is known as pathology test. Now we go to the last of the recurrent oral ulcers, which is recurrent herpes simplex. Recurrent herpes simplex, also known as recurrent herpes labialis, common cold sores, fever, blisters, precipitated by fever, menstruation, excessive UV exposure, and emotional stress. So this recurrent herpes simplex or labialis is precipitated by fever. Why it is recurrent? I hope you remember the virus was dormant and then it became active due to any situation or condition of the body, including febrile episodes or excessive menstruation or excessive UV exposure or emotional stress or any immunocompromised state. The virus came back from the nerve ganglion and reactivated. You remember they used a word in that slide, reactivation of the virus will cause a recurrence of the infection known as recurrent herpes simplex. And because it is usually mainly found around the lips, on the lips, that's why it is known as recurrent herpes labialis. Okay, perfect. Clinical picture, there will be prodrome. There will be prodrome of what? There will be tingling and burning sensation. First, there will be tingling and burning sensation, followed by edema and clusters of vesicles, local edema and clusters of vesicles at the mucocutaneous junction, where the mucus and the skin are joined. So this junction is mucocutaneous junction, then spread to the skin, is going towards the skin. So mucocutaneous junction spreading towards the skin, from the mucocutaneous junction spreading to the skin, followed by coalescing. By coalescing, they get together and weeping exudate. So they are followed by, so when they are spreading from mucocutaneous junction towards the skin, towards the periphery, they coalesce, they get together, and they weep out, exudate. They will, what they will do? Weep out, exudate. They will lose the fluid inside and then finally rupture and crust. I'm taking time so that you remember the clinical picture, the prodrome, how it occurs and how the lesions form and progress. So tingling, burning sensation, followed by edema and cluster of vesicles at the mucocutaneous junction. Then they spread peripherally towards the skin, followed by coalescing and weeping exudate. The exudate is been pushed out inside, the fluid inside has been pushed out, and then finally there is no fluid filled cavity. Then there will be crusting. There will be crust formation. Recurrent intraoral herpes inside the oral. Yeah, this is extraoral manifestation, right? So intraoral herpes, the vesicle will not crust. So what will they do is vesicles turn to ulcers. So ulcers are mentioned here. The vesicles turn to ulcers, mainly keratinized mucosa. For example, gingiva, heart plate. At that area, they will be formed. The ulcers will be formed. And then we have an overall view of the oral lesions. We have an overall view of the oral lesions. We have studied acute ulcer, we have studied chronic ulcers, and we have studied recurrent ulcers. Among this acute, we studied under multiple, not single. We studied multiple acute and multiple chronic. And then in recurrent, we studied some of them, like Behçet's disease. And then we studied, we do not have here, recurrent herpes, recurrent herpetic stomatitis. Okay, perfect. So this is an overall view. You can study by yourself. These are all the lesions or diseases which cause oral lesion and oral manifestation. Now we go to the next part of our class or our slide or our lecture, that is pre-malignant lesions of oral cavity. In this, we will study these 5 lesions. Pre-malignant lesions of the oral cavity will include leukoplakia, erythroplakia, placal lesion of reverse smokers, oral lesion penis, and oral submucous fibrosis. So 5 we will study here. Okay, so let's see what they are. Oral cavity cancer accounts for approximately 3% of all malignancies. That's why we need to know the pre-malignant lesions, so that when they are present, we can cure them, we try to stop them to become malignant. Oral cavity cancer accounts for approximately 3% of all malignancies, and it is a significant worldwide health problem. Most oral malignancies are squamous cell carcinomas. The malignant lesions are squamous cell carcinomas. The 5-year survival rate is about 50 to 60%. When we are studying, we do not pay attention to this. But actually, when some of the patient finally get a tumor, a cancer, a malignancy, then the most favorite question is, okay, doctor, we will go for the treatment. But after the treatment, what are the chances? What is the mortality rate? What is the morbidity rate? And what is the 5-year survival rate? So after getting the disease, after getting the malignancy and starting the treatment, the percentage of people who will survive up to 5 years is almost half of them. This is if they get the treatment, if they start the treatment. The 5-year survival rate is absolutely important when you go to hospitals, when you have to convince, or you should say, counsel your patient. Many oral squamous cell carcinomas develop from pre-malignant conditions of the oral cavity. So actually, the malignant or malignancy of oral cavity, the most common malignancy of oral cavity, squamous cell carcinoma, they actually develop from these pre-malignant conditions, lesions. It should be here, lesions. These are not conditions. Other than oral lesion penis, these are not conditions. Let's just go into it and change. These are lesions, except oral planus, which is a condition. Pre-malignant condition of oral. Okay. Perfect. So most oral squamous cell carcinoma develop from pre-malignant lesions of oral cavity, which include leukoplakia. Leuko means white. Erythroplakia. Erythro means red. Palatal lesion at the palate of reverse cigar smokers or smoking. Oral lesion penis. This is a condition, not a lesion. And then oral submucous fibrosis, OSF or OSMF. These are some of the pre-malignant lesions. Potentially malignant disorders are discovered most commonly on the buccal mucosa, lower gingiva, tongue, and floor of mouth. What are the most common places? These are the most common places for the malignant disorders. So we need to find pre-malignant conditions here. Among these, leukoplakia and erythroplakia is mostly found on the tongue and the buccal mucosa. What are the causes of cancer, of pre-malignant lesions? Tobacco. The use of tobacco. The use of tobacco has been well established as a significant risk for development of oral mucosa, oral squamous cell carcinoma, and premalignant lesions. So tobacco is one of the main cause. Second, alcohol use. Moderate to heavy drinkers have 3 to 9 times greater risk of developing cancers than non-drinkers or mild drinkers. HPV type 16 and 18 may be found in approximately 22 and 14% of oropharyngeal tumors we have studied before, HPV, papillomavirus. Warning features. If these are there, then it means something is wrong. What are these? Red lesions, known as erythroplakia. White lesions, known as leukoplakia. A lump or tumor, benign or malignant, we don't know. Any lump. Granular appearance of oral cavity or tongue. Ulcers with fissuring or raised exophytic margins. Abnormal blood vessels and supplying a lump. Pain or numbness. Loose tooth. Extraction socket does not heal, also a warning sign. Induration beneath a lesion, there is indurated. Firm infiltration beneath the mucosa. Mucosa has been ruptured and the spread has been gone to the next level. Fixation of lesion to deeper tissues or to overlying skin of mucosa is getting beyond the skin. The fibrous tissues are getting deeper or beyond the skin, causing an overlying mass. Voice change towards the pharynx, pharyngeal area, or lymph nodes of that area. Lymph node enlargement, lymphadenopathy, and subsequent weight loss, especially in the last 3 months or 3 to 6 months. Significant weight loss is a journal feature of any of the cancer malignancy. Okay, so this is the etiology of premalignant lesions. Then we go for some of the premalignant lesions of oral cavity. In this lecture, we will study leukoplakia, erythroplakia, palatal lesion of reverse smokers, oral lesion planus, and oral submucous fibrosis. Leukoplakia, white lesions. Erythroplakia, reddish lesions. Palatal lesion, a lesion in the palates of people who do the reverse smoking. Yes. Oral lesion planus, a condition, a premalignant condition of oral cavity. And then final, another premalignant lesion, oral submucous fibrosis. These all premalignant lesion, if not taken care, if not treated, can over time change into a malignancy of oral cavity, malignant lesion of oral cavity. The first one, leukoplakia. Leuko means white, a white patch or plaque that cannot be characterized clinically or pathologically as any other disease. So this is a diagnosis of exclusion. So when there is a white patch or plaque which is not associated with any other clinical picture of any other disease, then you can exclude this white plaque as a pre-malignant lesion of oral cavity known as leukoplakia. Leukoplakia remains a clinical diagnosis of exclusion because it does not have a clear clinical picture. Leukoplakia occurs most often in middle-aged and older men and arises most frequently on the buccal mucosa, alveolar mucosa, and lower lip. However, note that the lesions arising on the floor of the mouth, lateral tongue, and lower lip are most likely to harbor dysplasia and progress to malignancy. So, leukoplakia is mostly on the buccal mucosa, alveolar mucosa, where the bones, where the sockets are there, where the teeth attach to the socket, the maxillary mandible, alveolar mucosa, and the mucosa of that, the buccal mucosa, and then we have on the lower lip, leukoplakia, for the leukoplakia. But it's not limited to this, it can be anywhere else. But however, you remember, if something is in the floor of the mouth or lateral tongue and lower lip, they most likely to harbor dysplasia. They are most likely to change into dysplastic tissue and progress into malignancy. Perfect. So, what are the risk factors and etiology of leukoplakia? The whitish plaque, the whitish plaque. Risk factors for malignant transformation of oral plakia include. So, what are the risk factors when this oral leukoplakia will change into malignant tissue, or there will be a malignant transformation of this oral lesion? Advanced age, lesions of more than 200 millimeters square, bigger lesions, 200 millimeter is 20 centimeter, huge, non-homogeneous lesions, irregular, and higher grade dysplasia. If you take the biopsy or scraping or cytology of that area of the leukoplakic tissue of the tongue or any mucous membrane, then you find higher grade dysplasia. The cells cannot be differentiated. Then there is higher grade dysplasia, and is one of the risk factor for that the leukoplakia will transform into a malignancy, a malignant tissue. And that etiology, the cause will be almost the same, which is tobacco seems to be the major factor, both smoking and chewing. Chewing tobacco and smoking tobacco have the same effect, and this is the main factor of developing leukoplakia. Other than that, there's alcohol abuse, inadequate diet, vitamin deficiency, for example, especially A and C antioxidants, areca nut, also known as betel nut. Then there is chronic traumatic irritation, poor oral hygiene, poor socioeconomic status. And then we have causes of leukoplakia, which are smoking, chewing tobacco, secondary syphilis, oral infection, and HPV. So these are some of the etiology and the risk factors which can develop leukoplakia. And finally, these risk factors can develop a non-malignant or pre-malignant lesion of leukoplakia into a malignant tissue. So what is the treatment of leukoplakia? There are different treatments options for leukoplakia. However, the risk of malignant transformation is not completely eliminated by any of the current therapies. So there are different therapies and treatments, but this will not decrease the risk of the transformation. So better to avoid the causes, better to take care at this level, which you can modify. If you have developed leukoplakia, somehow if the patient has developed, then the treatment may not be successfully and completely eliminating the risk of that leukoplakia or a lesion, premalignant lesion, to develop into a malignant lesion. Initial treatment of white oral lesions, initial treatment is the elimination of the possible etiological factors, which are modifiable factors, which we can modify. And then there is complete surgical removal, leaving free lesion borders is recommended in case with epithelial dysplasia. And apart from surgical excision, other treatment modalities available include cryosurgery or carbon dioxide surgery, laser surgery, and retinoids, vitamin A. So minimal treatment of leukoplakia, the location is here on the right side. We see the on the right side of this screen, we have location where the leukoplakia is present. And then if there is no dysplasia, if we have seen that cytology and biopsy, this under the microscope, it does not show dysplasia, then we just observe, wait and watch. If there is mild dysplasia and it's on the tongue, fauces, vermilion, we remove. Otherwise, on the upper side, we watch anterior. And then if there is moderate to severe dysplasia, then we surgically excise it, we surgically remove it. And then this is the management of oral leukoplakia, provisional clinical diagnosis, elimination of possible causes and no possible causes. If there are some possible causes, we try to eliminate the possible causes for 2 to 4 weeks and then observe. If there's a good response, then there is definable lesion management accordingly. Try to avoid the etiology, the main cause of leukoplakia. And then if there is no response, then we go for biopsy. And in the beginning, while there is no possible causes found for the patient, then we directly go to biopsy. So if there is no response, if there is known cause, but there is no response after eliminating the possible cause, then we go for biopsy. And if initially there are no causes known for the development of leukoplakia, we also go for biopsy. And in biopsy, if there is dysplasia or no dysplasia, we go for the treatment. And if there is definable lesion, then we go for the surgery because it's definable lesion. And the second is erythroplakia. How it is different, erythro, it is because this is reddish orange patch. The clinical term used to describe a reddish orange patch, this patch, reddish orange, erythroplakia, that cannot be clinically or pathologically distinguished from any other definable disease. So same as leukoplakia, it's a lesion, it's a diagnosis of exclusion. The clinical appearance of erythroplakia is described as a red macule or patch with a soft velvety texture, most often occurring on the floor of the mouth, not roof, floor of the mouth, lateral tongue, retromolar pad, and soft palate. So this is the place where this erythroplakia will develop. While there is absence of other signs and symptoms, we just have a patch of reddish orange patch, erythroplakia. Erythroplakia is a worrisome clinical condition that often harbors dysplasia. So unlike leukoplakia, erythroplakia is a worrisome clinical condition. Leukoplakia may or may not have, depending on the high-grade dysplasia or the size of the leukoplakia, but erythroplakia overall, either small or big, is a worrisome clinical condition. Upon histological analysis or histopathology, 51% of erythroplakic lesions have been shown to demonstrate invasive squamous cell carcinoma. What do you mean by invasive? It invades other types of tissues and cells. That is known as invasive. Metastasis, easy to metastasize, easy to go to other places of the body, with 40% demonstrating carcinoma in situ. Carcinoma in situ is when they do not pass the basement membrane. So this is erythroplakia, and this is the background, causes, and diagnosis. So in background, we see painless, slow-growing lesion on mucous membrane of oral cavity, potential precancerous condition, worrisome condition, bleeds easily when scrapped. When we are taking biopsy for erythroplakia, when you scrap it, it will bleed easily. Whereas leukoplakia is here on the white left side. Causes also heavy smoking, either chewing tobacco or smoking tobacco, and excessive alcohol use are still the most common causes for this erythro and leukoplakia. And sometimes there is a mixture of them, erythroleukoplakia. Poor oral hygiene, long-term trauma to oral cavity, advanced age, and HP infection are also some causes, but most common causes still heavy smoking and chewing tobacco, excessive alcohol use. Diagnosis is totally medical history, examination, a diagnosis of exclusion when there is no other clinical picture with it. Biopsy is exfoliative cytology. You take scrapping, fluorescent staining. You have a fluorescent stain or dye, which will show you under UV light, there's some lesion, and then collodion blue stain is used for the fluorescent staining. This is blue, right? The plateau lesion of reverse smokers, we will go for after the break.